So we'll assume someone in the office will take care of that recording for us afterwards. I know Elizabeth is on and Mabinti's on, so that's great. Okay, going to spotlight myself for a little while. Okay. Here we go. Hopefully everyone's actually seeing the slideshow. Yes?
Yes.
Yes,
Thank you so much.
Yes, we can see it. Yeah.
Thank you for that. Yes, wonderful. Thank you. Good morning. Welcome. Maybe not morning for everybody. It is for me. Welcome to the Charitable Trust Brunch. My name is Kathy Wozniak, member of the Charitable Trust Board, and your host, along with Audrey Hobbs-Johnson, VP Education, for this session. And Audrey is here, and I will spotlight her as well, if I can find her. That's always the challenge for me. Unfortunately, Zoom doesn't allow for an actual brunch. This is billed as a charitable trust brunch. You're not getting any food from us over the screens. But there's also no voting, so you can put Election Buddy aside for for this hour. We are recording. You can be incognito if you wish, but please stay on mute. As this is a Zoom meeting rather than a webinar, as yesterday, one of the meetings was yesterday, please put any questions in chat and we'll monitor and get to them after the presentation. All right. So I'm just going to admit everybody. One of our other hosts could maybe admit others. There's Audrey. Thank you. Thank you for that. And someone spotlighting you. Thank you so much. And here we are. As we gather today, we acknowledge and respect First Nations, Inuit, and Métis people, traditional stewards of the land and water of all our communities in Canada. Situated on Turtle Island, our nation has been built on the lands of Indigenous people who have been living here on ancestral lands, ceded and unceded territories from time immemorial. As CFUW members, clubs, and individuals, we continually strive to increase and deepen our knowledge and understanding of our history, to go further on the paths towards reconciliation. I personally have found this explanation from the University of Toronto helpful of why do we do these land acknowledgements. Acknowledging the land is an Indigenous protocol used to express gratitude to those who reside here, to honor the Indigenous people who have lived and worked on this land historically and presently. It allows us the opportunity to appreciate the unique role and relationship that each of us has with the land, and provides a gentle reminder of broader perspectives that expand our understanding to encompass the long-standing rich history of the land and our privileged role in residing here. Through acknowledgement of difficult truths, we seek to build better futures together, to live in harmony, peace, respect, and right relations. May we work together in collaboration, walk together hand in hand on a path to truth and reconciliation. A little bit about the Charitable Trust. Charitable Trust raises money and administers funds for fellowships and awards. Is supported by CFUW, Canadian Federation of University Women, but in fact is a separate entity, is a charity, and that gives us that opportunity to give people a charitable receipt when they make their donations. Our investment is for women pursuing postgraduate studies and fostering future leaders for our communities and our country. Sorry, that's my email, and I'm just going to shut that out so it doesn't keep bing-bonging. It was established in 1967, but something interesting to note, and you see those numbers, they're nice big numbers, but the Canadian Federation of University Women, long before the Charitable Trust was created, was giving out awards. So just a couple of years after it was established, they were giving out awards, and then it took some time then to establish the Charitable Trust. It is an independent, as I've said, independent CRA registered charity. with our own board. You'll see those pictures in a moment. And now we have a different way. It's been just a couple of years. Universities Canada promotes and receives applications. And we have a hardworking fellowship committee that reviews and adjudicates the applications, processes the information every year, and works in teams of 2 per award. And you'll see how many awards we have. It's a lot of teams. This is our board. Hardworking, small group, and we do a lot, do a lot of work. A lot is done by the fellowships committee. And there they are. Sandra Thompson, who's on Zoom today, and her very hardworking group. And just a little plug, if any of you out there are fully bilingual, francophone, there's always need for more people to help with those committees. It's a little bit harder to find people who will be prepared to read the French applications. And here we are. And you see all of this, all the awards, the fellowships. There's a lot of money. We have legacy awards, and in a slide coming up, you'll see one of those scannable QR codes. If you want to give some money or find out more, perhaps about how to create a legacy award or some other kind of award, you can certainly do that. So you'll see there the Library Creative Arts Award. And this is the only award that's nominated by clubs. It's for a community organization that's been nominated by a club, $4,000. And it alternates. 1 year it's library, 1 year it's creative arts. So this year it's creative arts. And we congratulate Overture with the Arts, nominated by CFUW Montreal Lakeshore. Overture with the Arts, OWTA, is a Montreal-based nonprofit organization dedicated to empowering youth through free and low-cost programs in the performing, visual, and digital arts. For over 16 years, OWTA has provided equitable access to creative education for young people from underserved communities, especially on the West Island of Montreal. By fostering confidence, self-expression, and community engagement, OWTA has impacted the lives of more than 85,000 youth. And I'm sure they'll make very good use of this $4,000 award. Thank you to all the clubs who nominated. This year we had a lot of nominations. Please keep them coming next year when it's going to be the Library Award. Okay, here we are. Here's that QR code and how and why to donate to the Charitable Trust. And I'm not going to read all that, but there are tax receipts. So if you want to give a donation, that'll help you out at the end of the year with taxes. Okay. So next year, Charitable Trust AGM. Oh, sorry, this coming year. It's still this year. Saturday, October 4th at 1 p.m. Eastern Time. We have a speaker who's going to be talking about where are the working women? So a history of women's labor in Canada, particularly in Canada's natural museums, and you'll get lots more information closer to that time. Everyone is welcome to join us. We have a business portion of the meeting, but the speaker for sure you might find interesting, and lots of information will come on how to register for that. And I'm just about done. Thank goodness, right?
Kathy, can I jump in? I just want to make sure Jasper's on.
I don't know that I've seen Jasper.
No, I haven't either. So that's why I'm just thinking you might have to keep chatting while I have.
Okay, I'll keep, okay. Well, I'm going to take this off. Okay, I'm gonna stop the slideshow, and then we can just chit chat.
We'll
Oh,
just
I'm
check.
here. She says, from Kathy Washington.
Jasper's on.
I'm here. Okay,
Okay.
maybe she's used my link. Maybe that's why.
Okay, is she on? I just want to make sure she's there.
She says she's on. I'm going
That's
to
perfect. Okay, excellent.
remove my spotlight.
All right.
Okay. I'm gonna get out of this show. All right. And see if I can find her. But she's maybe used my link.
Oh, oops, it looks like I have. Let me
You have,
just,
that's okay. That's okay.
it says my name is your name. So do you want me to just quickly go back through the
No,
link?
no, stay on and you can just rename yourself.
Sure. Let's see if I remember how to do this.
Uh, that spotlight. Okay. It
Good
should be
morning.
the three dots at the top of your picture, or maybe I can do it. But you can do it. If you can't, I'll do it for you.
Perfect.
No, but it hasn't changed.
That work?
Yay!
Yeah, that's perfect.
There you are. There
Okay,
Oh,
you are.
it's
sorry.
always a new thing. Every time you do something, it's like it's the first time, I know.
Oh, yes, yeah. Technology for me, even like with being 24, still trying to figure it out.
Welcome, Jasper.
Thank you.
Kathy, would you like me to introduce Jasper
Yes,
now?
please. Yeah, please
All
go ahead.
right. So
Yeah.
it's good morning to everybody who was online this morning. I see there are 88 of us here early in the morning in BC. It's just after 8 o'clock in the morning. I've had the pleasure of talking to Jasper a couple of times in the last couple of weeks, and what an incredible young woman we have joining us this morning. So thank you so much for taking the time, and I know how busy you are. Jasper is a medical science student at the University of Calgary, and she's the winner of the Ecole Polytechnique Masters Award. And she's going to be presenting something to all of us on this morning have or will have some experience with women's health, Alzheimer's disease, and investigating the critical window of menopause. Something about Jennifer, she lives in Alberta and she's presently at the University of Calgary, and that's where she lives and her family lives. She did her undergrad degree at Western University in London, Ontario. At home, she's surrounded by a medical family that include her grandmother and father, who are both physicians, and other members of her family that do different things. Jasper has a passion for medicine that includes recognizing the critical role of patients, and she really values their perspective and knows how important it is to get to know her patients. On the other hand, she is just an incredible student, and she takes time for the research and clinical evidence that will support those two pieces. Welcome, Jasper. We're looking forward to your presentation this morning. And at the end of the just a bit of housekeeping for our colleagues that are on this morning. If you have questions, please put them in the chat. Kathy and I will monitor the chat, and then we'll, at the end of your presentation, we'll surface those questions. So good, welcome.
Thank
You
you.
now you can you have a PowerPoint that it should work really well. So
Okay. Yes, I can share it.
that's great.
All right. Can everyone see some slides?
We can. Thank you.
Perfect. All right, then I'll go on right ahead. So, good morning and good afternoon, everyone. Today, I'd like to talk and take you on a journey through women's brain health. Specifically, I'd like to focus on how the menopause transition may shape our risk for Alzheimer's disease. So, I'm going to walk you through what we know, what we're still trying to understand, and how my own research sorts of fits into this picture. So, although many of you may be familiar with Alzheimer's disease, I still think it's beneficial to describe it because there's so much that isn't taught on the disease. So, first and foremost, Alzheimer's disease is a progressive brain disease that causes brain death and impairs how we think, remember, learn, feel, socialize, and even function independently. It eventually results in death, and it is the most common cause of dementia. And although we may think of Alzheimer's disease as a disease that affects those in later life, many people don't realize that these brain changes can start 15 to 20 years before any clinical symptoms show up. So therefore, it's not just an old age disease, it's a disease that develops slowly over time, which may seem scary, but I like to think of it as this means more time for us to potentially modify our risk for further development of the disease earlier on. So kind of on this slide, what you'll see is that within this picture, we have a healthy brain, and kind of as disease progresses, we see that there is shrinkage. So that ultimately results in the brain parts atrophying. And it's also a disease that will continue to grow. So in fact, by the year 2050, it's estimated that 157 million people worldwide will be living with dementia. Within Canada, that's around 1.7 million people, most of whom are going to have Alzheimer's disease, though there are different types of dementia. And importantly, though, what I want to draw everyone's attention to is that 2/3 of these individuals will be women. So that's not just a statistic, it's a call to action. And to further put this into perspective, for women over the age of 60, the lifetime risk of developing Alzheimer's disease is actually twice as high as the risk of developing breast cancer. So despite this greater risk, knowledge and awareness, in my opinion, is something that is low and rarely discussed when it comes to Alzheimer's disease as a growing women's health issue. You might be wondering why women are more affected by Alzheimer's disease. And unfortunately, it's unclear. You might recall that Alzheimer's disease most often affects older adults. Age, indeed, happens to be one of the greatest risk factors for Alzheimer's disease. Furthermore, women tend to live longer than men, so it would make sense why women may be more impacted by Alzheimer's disease. Or does it? Because not all women develop Alzheimer's disease as they age, so that can't be the only reason. Rather, more recent research suggests that social factors, so things like our roles, our responsibilities, and even the burdens that we may experience related to, say, caregiving, our professions, daily life, as well as even cultural differences across countries, can contribute to the greater risk we see within women. But alongside social factors are also biological factors, which is where I want to specifically focus in on today. So, in particular, there's some research that has looked at differences in things like genetics and brain structure. But more recently, there is this idea that I and other researchers are interested in, which is specifically exploring hormonal changes and various biological events. And though there are many changes in hormones that occur in women throughout their lifespan, one major event that occurs typically 15 to 20 years prior to the average Alzheimer's disease symptoms onset is menopause, which describes the permanent ending of menstrual periods. But it's important to understand that menopause represents only one stage in a three-stage process known as the menopause transition. So you might hear me say menopause or menopause transition. And the menopause transition describes this entire process of ovarian aging, which is comprised of three stages. Perimenopause, which is kind of in that 35 to 45, 51 year range, where one can still have a period, albeit irregular. I also like to describe this as a point in which we see hormone levels kind of, if you can picture a toothpaste tube, you at the very end of that tube are trying to squeeze out just every little bit of toothpaste you have left. Sometimes it comes out in big spurts, other times there's nothing. That's kind of what perimenopause is in terms of hormones. But then we also have menopause, which actually represents one single day. It describes where a person is able to go, in the last 12 months, I haven't experienced a single period. And then there's postmenopause, which is life after menopause. And while many changes can occur during the menopause transition, one of the most profound hormonal changes occurs, and that's specifically in estrogen levels, which we can see from this particular figure looking at estrogen levels as a kind of as steady throughout pre-menopause, albeit kind of circulating due to the menstrual cycle. And then we see perimenopause and menopause and postmenopause where it goes down. And during and after menopause, we see, again, that estrogen levels drop significantly and they stay that way for the rest of one's life. So this may coincide with changes in the brain that increase vulnerability to Alzheimer's disease-related processes. So maybe this is a bit of a niche question, but I wonder if any of you have a favorite hormone. And the reason why I say this is because I want to tell you about mine. It's estrogen. Most of us know estrogen for its role in reproduction, things like the menstrual cycle and pregnancy, but it also has powerful effects on the brain. To name a few, estrogen plays a critical role in regulating mood, supporting memory, reducing inflammation, clearing toxic proteins associated with Alzheimer's disease. So maybe you've heard of proteins like amyloid beta or phosphorylated tau. If you haven't, don't worry. And all while estrogen helps to keep the brain connected and strong. In a very real way, I like to say that estrogen helps keep the brain sharp and resilient in the face of disease and injury. And when estrogen levels decline, as in menopause, these resiliency mechanisms may be snuffed out, contributing to a greater risk of Alzheimer's disease. And indeed, research is beginning to show this. So, for example, when estrogen levels decline during and after menopause, research shows that women undergo more brain atrophy, or that shrinkage that I was talking about earlier, than in comparison to men of the same age. So, the severity of this shrinkage also increases as women move through the menopause transition and beyond. So, this may seem like a lot for brain scans, but what I want to point your attention to is on the left-hand side, we have asymptomatic perimenopause. So these are the lucky ducks that don't get to experience any symptoms of menopause. Then there is symptomatic perimenopause. So these are people who do experience symptoms like hot flashes, night sweats, vaginal dryness being another, many. And then as well as postmenopause. And what I want to direct your attention to is the color on these particular scans, because what they're showing is actually the degree of shrinkage that is more significant in women than it is to men. So essentially, what we're seeing as it gets to the green, yellows, and reds are ultimately the degree to which women experience more atrophy than in comparison to men. And we do see that there is, as you progress through menopause and the menopause transition, a greater degree of that shrinkage. Not only do we see that with brain atrophy, but we also see that in the accumulation of proteins linked to Alzheimer's disease during and after menopause, in kind of the same way that we described in the previous slide. So, this critical period may be when long-term risk for Alzheimer's disease may begin to take root, and we specifically see that divergence from men in terms of risk for Alzheimer's disease increase. Now, to make sense of this scan briefly, it's very similar to the previous slide, where instead I want you to focus on reds, oranges, yellows. These are particular areas in the brain within women where we see there's a greater accumulation of these harmful proteins than in comparison to men. So these aren't showing up within men. This is only within women. And while these brain changes occur, we may begin to see changes in how we think, remember, behave, and function in daily life. And for some women during the menopause transition, these changes can be characterized as forgetfulness, difficulty concentrating, mental confusion, to name a few. And while I want to stress that for most women, these symptoms will decrease or altogether disappear with time, it is important to understand that these changes in memory, thinking, and learning, if persistent in later life, can be linked to warning signs for dementia. So to further illustrate this, we can take a look at some studies that explore differences in cognitive abilities over the course of the menopause transition. So for example, taking a look at this particular figure, we're going to break it down for you. Early postmenopause women tend to perform worse when it comes to verbal learning tasks, verbal memory tasks, fine motor skills, and finally, to a smaller extent, in attention and working memory when compared to premenopausal women, so women who have not entered the menopause transition, or those in perimenopause. So it's basically looking at the bars that are below that zero. That is where we see there is a decline in one's performance across a number of various thinking, memory, and learning tasks. And though these changes in how we think and remember can return to normal performance, and I always want to say that because nothing worries women more than telling them that these changes may be, warning signs for Alzheimer's disease, which is true, but Oftentimes, I find that when women really start to think about their menopause symptoms, this worries them further and instead makes the situation worse for them when ultimately these are changes that can return to performance levels prior to menopause. But again, what I really want to highlight is that it's important to understand that these changes, if persistent, can signal greater risk for Alzheimer's disease. It's also important to realize that changes in estrogen may not only affect how we think, remember, and even behave, but can also contribute to the experience of many uncomfortable menopause symptoms. So, as I kind of described earlier, things like hot flashes, night sweats, sleep disturbance, vaginal dryness, weight changes being another, brain fog, and so forth. In fact, there was a recent article that described that there may be 30 plus different menopause symptoms, one of which being a burning tongue sensation, which I just think is very interesting. It's probably unsurprising then to hear that many women, at around 75 to 80%, struggle with menopause symptoms. And for some women, these symptoms can be life altering. They prevent women from working, socializing, and moreover, functioning and feeling comfortable in their own skin. These symptoms also can go on for years. So, over my time volunteering at a women's health clinic in Calgary, I have heard countless stories from women describing how their menopause symptoms were one, often dismissed or ignored by healthcare providers. And that's ultimately because there just isn't much in terms of medical education for menopause. But two, these menopause symptoms also inhibited their ability to live their life fully and unencumbered by their menopause symptoms. So, dealing with the burden of symptoms for years can impact how we think, remember, interact with others, and function on a daily life. And given that these impairments can last for years, it's driven researchers, including myself, to wonder if this sustained burden makes women more vulnerable to later brain changes related to dementia. Moreover, it's also important to note that not all women experience menopause symptoms. Which begs the question, why do some women experience menopause symptoms and others don't? Are those who've experienced menopause symptoms more susceptible to later brain changes than those who haven't experienced menopause symptoms? And indeed, in my work, we've begun to see that they do. So, in particular, women who have experienced a greater number of perimenopausal symptoms compared to those who've experienced none or fewer reported poor thinking, learning, memory, mood, and even social behaviors in later life, all of which are risk markers, as we know now, for Alzheimer's disease. And in addition to my own work, other researchers have noted that specific symptoms, like hot flashes and night sweats, which also happen to be the most common of menopause symptoms, may also associate with greater buildup of harmful proteins associated with Alzheimer's disease. So, in case anyone is interested, I just thought I would include the articles that I've written about, this being one in Plus One, which is the more scientific article. But I want to also point your attention to the conversation piece on the left-hand side, which is both of these are free to read, but the conversation, I like to break it down so that it's understandable and not too stat heavy in terms of the Plus One articles. So I'm happy to send those along if anyone's interested. But back to the presentation. Now, often prescribed to help alleviate menopause symptoms is something called menopause hormone therapy, or MHT, as you might hear me say for short. And many of you may be more familiar with its earlier name, which was hormone replacement therapy, or HRT, which both of these help supplement the declining levels of estrogen we see during menopause. The only difference in terms of naming is actually that we have transitioned to using MHT as compared to HRT now, because HRT is meant to define individuals who go through premature menopause. So this may be because of surgery, chemotherapy even, and we are therefore replacing estrogen levels that were too low. Whereas if you go through menopause naturally and you take MHT, that's because you aren't replacing at that point, you are just helping to supplement. So, given that low estrogen levels combined with the experience of menopause symptoms may be linked to greater risk of Alzheimer's disease, and we know that MHT helps with both of these factors, research has begun to wonder whether MHT may also confer protection against later risk of Alzheimer's disease. Unfortunately, though, this line of research is highly debated and findings remain largely inconsistent for a number of potential reasons. And we're going to try and break that down. So, for example, one of the largest and most well-known studies some of you might be familiar with is the Women's Health Initiative study, which first explored how a combination of estrogen and progesterone MHT may prevent later life conditions like cardiovascular disease, stroke, and cancer. And a later version of the study, the Women's Health Initiative Memory Study, or WIMS, explored how MHT may prevent dementia and something called mild cognitive impairment, which is an earlier warning stage for dementia. And unfortunately, as many of you might know, the results of this study were not comforting. MHT was linked to increased risk of cardiovascular disease, stroke, cancer, mild cognitive impairment, and dementia. And the results of the study were also immediately felt. Women became scared to take MHT, and healthcare providers also became very hesitant to prescribe it. In fact, I was reading an article recently that described this change in prescription and use levels of 48% to then 14.2%. So it dropped. And while this study is important, and I do want to really emphasize that, there are important limitations as well to the study that must be discussed in order for us to understand whether MHT is linked to Alzheimer's disease risk or resilience. So firstly, it's important to understand who MHT is normally prescribed to. So MHT is commonly prescribed to women who are recently menopausal, be it even within perimenopause or postmenopause, and oftentimes these are individuals within their 50s. They don't have contraindications for the medication. So, contraindications essentially being things like a family history of cardiovascular disease, stroke, breast cancer, uterine cancer, and so forth. And most importantly, these are women who are experiencing menopause symptoms. But for most women in the WIMS study, most participants started MHT at 65 years of age and older. And many of these women also experienced little to no menopause symptoms for years. So, moreover, this study also did not exclude participants with family histories of cancer, cardiovascular disease, or stroke, which normally today, physicians, if they understand your history, family history for cardiovascular disease, cancer, or stroke, will oftentimes not recommend MHT. So, thus, in this study, MHT was kind of used like a one-size-fits-all approach to helping protect against serious health conditions. And unfortunately, MHT must be personalized to the individual person, and it needs to consider each person's history and reasons for the use of MHT. Moreover, MHT should not be used to prevent a disease. Rather, I always like to emphasize that when used appropriately, it may help protect against a disease, but never be the one solution to preventing a disease, especially when it comes to something as complicated as Alzheimer's disease. And I'd also like to highlight on this slide, at least too, is that not all women can take MHT, nor do all women want to take MHT. So if we were to use MHT as this kind of one-size-fits-all approach to preventing all of these different conditions, we leave many women at a disadvantage because they can't take it. So I think we need to do better and explore other options. But it's important to note that without this WIMS study, we wouldn't be where we are currently in terms of research. And where we are now sheds light on the idea that it's not just a simple use of MHT that we should consider in terms of where it or whether it protects, has no effect, or harms women's risk for Alzheimer's disease, but rather we must consider how factors related to the individual user, in addition to the specific MHT, used together can influence risk and resilience. So specifically, recent studies have focused their attention on how formulation, so things like is it estrogen or progesterone based? Is it a combination? The dosage, is it high or low? The duration of use, are you using it for 4 years or are you using it for extended periods of time? And even the timing of initiation. Are you starting this right after menopause, in perimenopause, years later? All of these are important factors to consider for risk and resilience to Alzheimer's disease. And though this research is still unclear, there is emerging evidence that suggests that estrogen based MHT, initiated closer to the age of menopause, may confer neuroprotection rather than harm. But I always want to emphasize, especially when it comes to MHT, research is still very much needed in this area, and we need to explore more. This brings us to where current research stands today. But importantly, it also brings us to where we need to go next. So, one area that I am particularly interested in exploring is how the menopause experience itself may relate to other warning signs of Alzheimer's disease. And while changes in memory, thinking, and learning are often top of mind for good reason, it's important to realize that Alzheimer's disease doesn't just affect cognitive domains, so things like thinking, learning, and memory. It is also linked to changes in behavior, things like mood, personality, and even how we socialize with other individuals, and further, as well as how we function on a day to day basis. So, for example, um, are you able to pay for your own bills? Are you able to go to a grocery store and collect various items? Are you able to walk up and down stairs? Mobility, as well as that, being able to kind of function on a day to day level in terms of daily tasks. These changes can occur actually independently of cognitive changes and even show up before memory problems begin. So, therefore, understanding how estrogen levels, menopause symptoms, and MHT use may associate with behavioral changes and functional changes, in addition to those changes in memory, learning, and thinking, will give us the opportunity to better identify women at greater risk for Alzheimer's disease earlier on. And by expanding to include this triad of symptoms, cognition, behavior, and function, we may have a better picture of how the menopause experience may shape risk markers of Alzheimer's disease. And indeed, in my own research, I have been able to observe that low estrogen levels may be linked to greater behavioral impairment symptoms, sometimes even in the absence of changes in cognition. And by behavioral symptoms, I mean changes in our motivation, our mood, our impulsivity, social behaviors, and even our perceptions and thought content. These are things that can change and can be warning signs to look for too. So, by observing that behavioral symptoms are linked to estrogen levels, even when they aren't always linked to cognitive symptoms, this may suggest that behavior could be more sensitive to estrogen changes and further indicate important warning signals for later Alzheimer's disease risk. So, on this particular slide, what I want you all to understand is that lower estrogen levels were associated with greater symptoms of something called mild behavioral impairment, which essentially is just describing persistent and later life changes in our mood and personality, which can be warning signs for Alzheimer's disease. And this can occur among individuals 50 years of age and older. And remember how I talked about the connection between MHT and cognition, so thinking, learning, and memory, and how that area of research is somewhat unclear? Well, within this study that we ran, we found that while MHT use did not associate with cognition or link to it in terms of helping to kind of better performance or protect your thinking, learning, and memory, MHT use did help to reduce the severity of behavioral symptoms. So, again, those changes in motivation, in our mood, in our social behaviors, and so forth. So, this may suggest that MHT use could also protect against Alzheimer's disease through multiple pathways, not just restricted to cognition, but also potentially behavior. Moreover, as touched on earlier, menopause symptoms may be key to understanding a woman's risk for dementia. For too long, menopause symptoms have been hidden from the public view, but these symptoms themselves may hold important clues to a woman's ability to withstand later changes related to dementia risk. And it's my goal to better understand how menopause symptoms, be it the burden of symptoms, so that being the number and severity of symptoms, or even the type of menopause symptoms experienced, may link to clinical risk markers like cognition and more broadly, behavior and function, as well as then biological risk markers, so such as those harmful proteins that I talked about earlier. And it's through this ongoing research that I seek to explore something called a menopause endophenotype of sorts, is how I've kind of been describing it. Essentially, what I want to explore is how different aspects of the menopause experience, including hormone levels, menopause symptoms, and MHT use or no MHT use, may together be used to create personalized risk profiles for women. And by studying these factors together, we may be able to better identify risk and resilience for women's brain health, allowing us to detect those at greater risk and implement intervention strategies sooner rather than later. So, here are two major studies that I am part of currently seeking to explore these relationships. One being the biomarkers in mild behavioral impairment study, which is only Calgary based. But this project, I actually look at estrogen levels and how it's associated with things like cognition, behavior, and function, as well as more of those harmful proteins. And then there's also Can Protect, which is a national online study. And this, anyone can join, but essentially we seek to explore how people are resilient in their aging. So, suffice to say, there's still so much that we don't know when it comes to Alzheimer's disease risk and resilience. But one thing is clear: menopause may represent a critical window not only for vulnerability, because I think that's what a lot of people will consider, but also prevention. Because if we're able to understand where vulnerability occurs in the menopause transition, we can then act earlier to help these individuals be better prepared to fight off Alzheimer's disease, prevent it, or slow progression. And it's my hope to be able to contribute to this fascinating and much needed area of work. So, with that, I'd like to thank you all for your attention and engagement. I'd also like to thank the CFUW for their support and enthusiasm for my master's research. And I hope that this talk sparks curiosity, maybe even conversation. Your experiences are critical, and this research is not possible without the voices of menopausal women. So I'd love to hear any thoughts or answer any questions. And if you're interested in joining any of these studies or would like to have more information on these potential links, then please do not hesitate to reach out. So with that, thank you all, and I'd like to open it up for questions.
Thank you, Jasper. I'm looking at a couple of questions, and Kathy will be looking at them too. Lynn Ken put one in early. When males take estrogen for transgender, does that help their brains?
That's an interesting question. And unfortunately, there's just no research really that's exploring it at this point. But if we're thinking about the mechanisms by which we learned estrogen kind of works by, then I could see it potentially kind of conferring some level of protection for your brain. But
Okay.
it definitely needs to be studied. And this is certainly an area that is underexplored, even within hormones and Alzheimer's disease risk.
I'll do one more and then I'm going to throw it over to Kathy. But Kathy's or Linda Sestock has a comment that doctors seem frightened of estrogen therapy. Can you talk a little bit about that?
Absolutely. So that stems to the WIM study, which essentially was describing that a combination of estrogen and progesterone hormone therapy was linked to increased risk for Alzheimer's disease, other types of dementia, in addition to mild cognitive impairment. And not only that, but it was also associated with greater risk of breast cancer, uterine cancer, cardiovascular disease, and stroke. So that has ultimately led to a lot of physicians and healthcare providers being quite hesitant and scared to prescribe this treatment. But Ultimately, we do need to understand that there were significant limitations to the WIM study and the Women's Health Initiative study overall, where when kind of personalized, as I always like to really just press on, when personalized to the individual person, HRT or MHT is now known, can be incredibly helpful for women, and especially when they are experiencing menopause symptoms. So the hope is with all this new current research coming out suggesting that it can be safe if personalized to the person, that hopefully we see this kind of change. From the previous hesitancy to more so being able to confidently prescribe it and know that it can help women.
Thank you. Linda just put one in. What about the statins? Do you want to say anything more about those, or
Sorry, the
statins, STATINS, Linda Sestock. Linda, do you want to just pop on and ask your question?
Oh, hi. Sorry. It's just I've had some doctors actually mention because statins are given when I believe you have high cholesterol, and
Right.
some of us are afraid to take medication. But
Mhm.
I've heard from some doctors that that medication could help with Alzheimer's. So I was just wondering if you'd heard that.
No, I mean, there are quite a few medications actually focused when it comes to Alzheimer's disease treatment that are something called cholinesterase inhibitors, but that's more of a choline kind of mechanism. For cholesterol, this is getting at the fact that with Alzheimer's disease, things like neuroinflammation, higher blood pressure, and so forth, and cholesterol levels can ultimately increase your vascular burden. Um, so the hope is by being able to modify, say, cholesterol levels that might help to reduce risk for Alzheimer's disease, in addition to a whole host of other chronic conditions in later life. So I can see how that might actually benefit, but in terms of directly decreasing your risk for Alzheimer's disease, I'm not sure.
Over to you, Kathy.
Jamie, maybe you could stop the share and then,
Sure.
yeah. Okay, so question about experience of concussions. Complicating analysis, which hormones affect the risk for Alzheimer's? Huh.
In terms of concussion risk or?
Well, the question is, from Sandra Shaw. Sandra, unmute yourself and ask the question. Maybe you can be clearer with it when you speak.
Okay, the question is, if you have experienced a traumatic brain injury or significant concussion at some point during your life, my understanding is that it increases the risk for Alzheimer's. And how does that then complicate analysis of hormones and hormone therapy trying to mitigate the risk for Alzheimer's disease?
That's a great question, and one that definitely should be further researched. So, as you pointed out, is concussions and brain injuries do and are associated with greater risk for Alzheimer's disease and dementia. But in terms of how it then relates to hormones and, say, the use of MHT, less clear, I would say, which is kind of ironic because we also understand that there is a growing number of domestic violence. So, for example, concussions and injuries can occur from that within women in particular. Um, as it relates to MHT, it may be the case that this might help protect your brain, possibly, although I always like to preface that more research certainly needs to be done in this area. And we think of that in terms of, say, estrogen levels. Not only is it important for maybe the ways that we have our brains connect, but it's also important for another process, which is known as neurogenesis. And that's being able to produce more neurons, which is all very helpful and protective for your brain against fighting against things like Alzheimer's disease. So, in that way, I would say that potentially it could confer protection that way, but ultimately, further research just needs to be done in this area overall. And you've highlighted one of the specific areas.
Thanks, Jasper.
Of course.
Kathy? We have time for a couple more questions, I think.
Okay, well, okay, it's a question for postmenopausal women. Is there research on HRT for postmenopausal?
Yes. So actually, I would say that the bulk of research explores postmenopause women and their use of HRT or MHT. And why we're interested, especially within this group of women, is also to note that menopause symptoms can change throughout that entire transition. So the symptoms you may experience during perimenopause may be completely different in what you experience postmenopause. And the severity can also be different. So that's one reason why that's being explored. But another is as it relates to the initiation time for MHT, where it's been suggested that later starting of MHT in postmenopause may be associated with greater risk for Alzheimer's disease. But as the WIMS study really highlighted, this can be seen within women who take MHT for the first time, 65 plus years of age. These are postmenopausal women, but may not necessarily be helping them in the way that it would for someone that's more recently menopausal. So still postmenopausal, but maybe a year out from it as compared to 15 to 20 years. So essentially, that research is suggesting that early initiation of MHT may be more protective than in comparison to later use of that. And that also comes from some theories which suggest that maybe your brain has become used to the lower estrogen levels. And so by supplementing it with estrogen or progesterone, hormone therapies, that might be kind of not having any effect on brain tissue and regions that have just adjusted to lower levels and may be injured or kind of just no longer require that amount.
Hmm.
Yeah,
Okay.
it's very interesting.
Okay, yeah. Fiona in BC has a question. For those of us who can't take MHT because of family medical history, what prevention protocols are being considered against Alzheimer's?
Yeah, and that's a great question and one that I'd like to be able to explore further just because I think there is this hyper fixation on MHTs kind of being used as this almost universal solvent, which it just can't be treated that way. So, as it relates to other potential therapies that might work, I always like to say that being able to treat menopause symptoms may be one of the biggest things to do that doesn't just happen with MHT, but potentially if it's mood or cognitive changes, being able to consider other medications that might help to lower those particular experiences, so cognitive and behavioral changes. Usually that can be with various mood medications. But I'd also like to highlight another one that is often not described much, which is vaginal dryness and being able to use various creams that works. That can be hormone-based or not. So sometimes gels are also suggested, or even lubricants too. The number of women that I have spoken to who have described vaginal dryness as basically preventing them from being able to go about their life on an everyday basis and socialize is pretty shocking and ultimately can have large ramifications for their later life if they just go years in this state of burden and distress. So I think being able to treat menopause symptoms is really important. MHT is oftentimes kind of like the go-to, but as you've pointed out, because of family histories, not everyone can take that. So at this time, I think there's a big push now for other therapies to be created. And so it's just a matter of time before that really occurs. So hopefully that at least attempts to answer the question.
One more question, Kathy, and then I think it's 8:56 on my clock.
Yeah, yeah. Oh, okay. So is Alzheimer's more present in women than men?
Yes.
Hmm.
Yes, so Alzheimer's disease, at the beginning of the presentation, I kind of described currently and in the future, we see that 2/3 of those with Alzheimer's disease are women. So in terms of prevalence rates, we see that. It also depends on country too. But we do understand that women tend to be more impacted by Alzheimer's disease. And previously, that was because of the idea that we just live longer than men. But what we're finding out is that there are other earlier events that occur that can also increase this risk.
Thank you. I want to end with a piece of really good news from Marjorie. She said, I took HRT therapy for about 35 years. I am 98 and treasurer of our club. So
Here we go.
there we are. There's our good news. And then just to say thank you, Jasper, for all your work, for taking time to talk to us today, but for taking time to do all this work. And I've really enjoyed getting to know you over the past couple of weeks. And to in thanking you, say how we are all concerned about the paltry funds dedicated to women's health research. And the research has been done is often not included in curriculum at medical schools. So as CFUW members, we really need to pay attention to this. And I'm so excited you have this scholarship and that you're doing the work. And I know that we'll keep in touch and be interested in what you're doing. So thank you so much for your doing today. We will let you see the questions because some of the questions, we didn't have time for them all, may help your research. So
Yes,
thank you. Do you have a last word for us?
Well, first and foremost, thank you all for being here today and listening to this presentation. Moreover, thank you for the scholarship opportunity. Your work matters, and the way that you're able to support women like myself is what pushes fields forward. And I want to really say that at the heart of this research is menopause women. Your experiences really create the research that I do, and your voices need to be heard. So my hope is that I can give a platform for you all to be heard on.
Thank you. And we wish you all the luck and we'll be in touch. Oh,
Yes.
back over to you, Kathy.
Thank
Thank
you.
you. Just a couple of just little messages from, I think this must be from Elizabeth. If you have it already registered for the AGM policy session that starts at 12:30, there's a link there in the chat. And if you weren't able to vote yesterday, the doors will open early at 12. So basically, as soon as we are finished here, we'll finish here, and then it's the same platform actually. So I have to finish so they can open the doors, so to speak. And if anybody had trouble voting, then please go on a bit early so that can be taken care of before the meeting starts.
Right.
Kathy, just a quick word. So we would encourage everyone to donate to the Charitable Trust so that we can continue to give scholarships to these young, bright women that are our future. So please donate. You can do it through the website. You can do it through the QR code, but we would appreciate all the support that you can give us. Thank you. Thank you, Kathy.
Thank you. Take care, everyone.
Thank you again, Jasper.